Today we're joined by Mark Middleton, Global CEO of Icon Group. Icon Group is Australia's largest cancer care provider with a growing footprint in Singapore, mainland China, Hong Kong and New Zealand. Of particular note for today's interview, Mark has been involved in leadership roles across oncology services since 2007, where he was CEO and founder of Radiation Oncology Queensland, while also working in cancer care across North America and Europe prior to this. He stepped into the role of Icon Group Global CEO after the acquisition of Radiation Oncology Queensland in 2015. Since this time, he's led a period of significant growth in Australia and has taken Icon successfully to international markets. Icon now features over 35 centres across the country, either in operation or the development pipeline. Mark, thanks very much for the time. We'll jump straight into the first question specific to yourself, but can you provide the viewers with some background into your history with oncology and oncology services, the key drivers, I suppose, that made you select this industry as a career path of choice from the start?
Yeah, no, great. Well, firstly, thanks for the invitation to come and speak with you. And well, look, I think if I go back and look at choosing a career when I was obviously finishing school and heading into university, I wanted to do something that helped people. As we all know, cancer is a disease that ultimately touches us all, whether it be personally, family members, friends, it will touch us all. And I wanted to be involved in that where I could help people. The reason I chose to be a radiation therapist is I also love technology. And the innovation and technology in our field, across all of oncology, but specifically for me at the time, radiation oncology, is simply amazing. It's something that still excites me to this day, is how do we harness innovation and technology to help people? So there's two factors. I wanted to help people and I love technology.
You published a book late last year titled Good Morning, How a Crisis Delivered Inspiration to Lead. What was the impetus for writing the book? And what are probably some of the key lessons people could pick up as a takeaway when they read that book?
Yeah, well, look, it's an interesting question. I never really set out to write a book, although I'm very, very glad that I did. The book is about, I have a ritual that every day that I'm in the office here in Brisbane, I committed to people that I would come around and say good morning to every single person, which I still do. When you send everyone home to work remotely, the question in my mind is how do I stay connected to my people? How do I keep my people connected with each other? So I just happened to be driving to the office on the morning that I had sent everyone home to work remotely, and I decided I would stay in the office. And I thought, well, I'm going to email everyone good morning, and I did. And that started, the most satisfying element of my leadership career thus far, where I was able to communicate with everyone, 3,000 team members around the world, every single morning by saying good morning. And it wasn't so much my emails that were the powerful part, it was the responses. It was the responses from people and the connection that we were able to form. So, look, I asked our people to live by 3 simple words: stay calm, stay connected, stay committed. And I learnt an awful lot about leadership from that book. So if anyone's watching, they want to read a good book, I can highly recommend it.
With the good morning piece, was that an email? Was that a Teams? Was it a Zoom? Like how were?
It was an email to 3,000 people every
Yeah.
single morning, and it was translated into Mandarin
Yep.
every day for the Chinese team, and that in itself brought some interesting connections. The translation of some English words into Mandarin that I didn't think the Chinese team would know, and they did. We're talking about musical groups and books and all those sorts of things. So, if anything, it just brought the team closer together. And I often say this: how many organisations can say they are a better team on the other side of a global pandemic than where they were before it? We can say that, and that is saying something, because we were a very good team before.
Now, pushing across to oncology services in particular, while they're pretty well present, at least in metropolitan locations, or at least it seems on a surface level, what's your view on their positioning and availability in regional locations? You've obviously had a bit of a big push toward expanding into a lot of regional locations. Is there a specific reason, and what's your view on the supply and demand kind of ratios for those services in regional parts of Australia?
Well, I think we're very fortunate in Australia, firstly, that we have a very strong public health sector and we have a very strong private health sector. However, there are still a lot of areas in Australia that have a lack of access to cancer care. And I'm talking about both the delivery of chemotherapy and radiation therapy. And you're quite right. Traditionally in Australia, cancer services were in metropolitan settings in major hospitals. As the technology and the innovation has continued to evolve over really the last 10 to 15 years in Australia, we've seen more and more out of suburban cancer centres and indeed regional cancer centres. And we've been real pioneers in that. As you know, my first cancer centre was in Toowoomba in regional Queensland. So it's important that we actually go to places where people live and provide access to patients where they live. There is a lot of evidence in oncology literature that the further you live away from a cancer centre and the further you have to travel, that can negatively influence your outcome. So we're working really, really hard to provide more access to more people. I mean, it's no surprise that ICON's motto is the best care possible to as many people as possible, as close to home as possible. So there's a lot of areas in Australia that still require access to radiotherapy particularly, and you're certainly going to see ICON continue to fill those gaps.
And locationally, what's the strategy? Is there a set strategy? Do you prefer co-location with hospitals? Will you look at standalone clinics? Do you need to be near a hospital at all? Do you need to be in a precinct? What's the kind of preference? Is it scattered across the portfolio?
Well, it's different across the portfolio, absolutely. And I think in different locations there are different requirements. We have a lot of co-located hospital sites with all of the major hospital groups in Australia, both public and private. We also have a lot of standalone facilities as well. It's really about the location, the demographic studies you do, the population size, cancer incidence, is the population ageing? How far are people travelling from that location to other locations for treatment? So it's a very, very sophisticated analysis, which ultimately also gives you the answer about should you be co-located with a hospital in this particular location or should you be standalone in this particular location. It also comes down to the strength of your medical team. Where are your doctors? Who are your doctors? What is their, I guess, referral bases in those areas? So it's a really sophisticated piece of work about choosing the right location.
And in terms of ICON's property model, is there a preference to own? Is there a preference to lease? Is it exclusively leasing? Obviously, the fit outs would be fairly capital intensive with the bunkers that are required and things of that nature. Is it pretty set in one way or another?
Well, again, we have a degree of flexibility about how we approach locations and indeed partners in those locations. We're not property owners per se as a company, although many of our individual team members have property ownership as part of their investment portfolio, including many of our doctors. And that is a very, very attractive opportunity for our medical teams, is to own the facilities in which they also practice, and you can understand that's very attractive to doctors who are starting out on their careers. And if you speak to many of our senior clinicians, they would say that was an important part of setting themselves up in terms of an investment approach. So again, we take a different approach in each location. We've been responsible for fit out in many locations. We've been responsible for design and construction, and without necessarily owning the building. So I think what ICON brings to the table is quite a flexible approach to get the best outcome in the individual circumstance.
Do ICON have an estimated kind of capital life when you move into a building? Is it tied into renovational clauses? Is it linked to the LINAC machines in particular? Obviously in the past we've had experience where leases are linked in with the estimated life of those machines as well, given the costs associated.
Yeah, well, we tend to take a different approach to that. I mean, a LINAC has a lifespan of 8 to 10 years, and we continually upgrade technology, and I think that's what you need to do to stay at the forefront of cancer care. If you're going to deliver the best treatment to patients, you've got to be continually evolving and updating your technology. And that may actually happen before 8 years, which is why we take a different approach. We don't tend to link the facility to the life of the machine. In terms of renovation and refurbishment, again, trends change, and you would have seen over the years medical facilities fit out changes, and it changes regularly. And I think you have to continually update. So we don't tie that into the LINAC's life, but we do tie it into making sure we give the best possible patient experience. So if facilities are old and they're tired, we need to renovate them and we need to refurbish them. And that's what we've done throughout ICON's history.
And you touched on this in a previous question, but when assessing a future location, is it based on outsourced demographic studies? Do you have an internal team? Is it based on patient data? How would you kind of drill down into the selection of a specific location for Icon?
Yeah, well, look, it's absolutely based on patient data and some of those things I mentioned. Population base, ageing profile of the population, cancer incidence in the area, either supply or demand of services in the area for cancer care. I don't think anyone's interested in putting a cancer centre next door to where there already is one. So we always take a very rational approach to that competitive nature of healthcare. What it really is about, though, is doing sophisticated analysis of all of that data. Now, in years gone by, we did outsource that approach, and we had a partner that we worked with regularly, and we actually built a model on how we identify locations. We now do all of that internally. We have got a specialised and highly skilled projects team who've deployed probably more cancer centres than anyone else around the world now. And they're able to do all of that work internally, which we find very, very powerful, because I'm able to have conversations like this, identify opportunity, and then we're either able to support it or say no because of the data.
When negotiating leases with landlords, how do you go about the process of setting an agreeable or a feasible long-term rental? For Icon, is it through an arm's length valuation? Is it through referral data or forecast patient data? How do you go about that and work with those developers or landlords to get an agreeable lease in place?
Yeah, look, we tend to focus on an arm's length valuation of the facility and indeed the precinct and comparable facilities nearby. That's the way we've always done it. I think some of the other factors you allude to, we are starting to see that more and more in the market. And again, we take a flexible approach for the right location, but it's usually an arm's length valuation taking into account other healthcare precincts in closer proximity to the location that we're looking at.
Both government support for the healthcare sector and private health insurance costs, probably in particular, have been pretty major talking points and consistently over the past few years. What's your view on private health and government support for the sector in recent years and moving forward, and where do you think it could head?
Well, look, again, we're very fortunate in Australia to have a very supportive public health sector. Obviously that's state by state in Australia, and we formed very strong relationships with the public health services in each state, because often we're partnered with them. I think the other point I'd make around the strength of our healthcare ecosystem in Australia is the strength of public-private partnerships, which we have multiple of in Queensland, New South Wales and Victoria, and they work really, really well. So we do have supportive government. Certainly a big factor in us being able to take radiation oncology regionally has been a Commonwealth grant system which is called the Radiation Oncology Hospital Program Grant. There is no doubt that has allowed more services to be based in regional Australia. So we're very fortunate in that regard. I'd certainly like to see more collaboration and cooperation between public health systems and private health systems. I think when done really well with the appropriate checks and balances and frameworks, that can work extremely well, and we've got examples of that. Look, private health insurance, again, really solid relationships. We're fortunate to have choice in Australia of who is your private insurer, and I think we're seeing more and more services covered. But again, that's also an important factor in location. Where are you going to choose a location? Because often the private health insurance companies will have data that either supports or doesn't necessarily agree with the location of certain facilities. So I'd like to see more collaboration between all of those parties. I think anytime you can bring the key stakeholders to the table to talk about patient outcomes is a very, very positive thing.
Where do you see the future of cancer care heading in Australia? Are there any specific innovations that are on the horizon that excite you moving forward?
Well, look, I think we're going to see, and we're already seeing some of it, the capacity of the things we're talking about, taking cancer services close to where people live. For example, we have a new radiation oncology facility about to open in Mildura, which is a place where people have had to travel extremely long distances to either Bendigo or Melbourne for many years. For a long time it was thought you couldn't deploy radiation oncology to a place like Mildura. We're about to. We have innovative approach to smaller linear accelerators, smaller radiotherapy bunkers, and we're able to support staff in Mildura from what is a global network for ICON.
Yep.
So certainly the world's changing and the world's evolving in taking cancer care to places where it really needs to be. So I want to see a lot more of that. And obviously that's a global opportunity as well for someone like ICON. It's not just about Australia. Take cancer services to where people live. To do that, you've got to have ever-evolving technology, you've got to have innovation, you've got to be able to connect people across networks, all of those things. But I think you will see more and more regional cancer care in Australia as we move forward, which is obviously an opportunity for your sector and also our sector to continue to work really closely together.
I'll just piggyback off one of those items you raised with the bunkers, because a lot of the developers and the institutional groups that our team deal with are of this view, and I think it's changing, and you've probably just mentioned an example of it, that if they want oncology, they have to build significant bunkers in order to have that in their clinic. Are there alternative options that you see coming now? Or you said smaller bunkers or mobile bunkers as well?
Yeah, no, there absolutely is. The technology has evolved significantly over the last really 5 years. And we have across our network almost every example of bunker built. The traditional concrete bunkers built as you alluded to, they're big, they're expensive, they're built often before you have someone in those facilities. Or there indeed is the approach that we've taken, brownfield developments, adding bunkers later on. You know, we've done that at multiple locations across Australia now. So there is a degree of flexibility, but I think I would suggest to all property developers who are looking at oncology related locations, engage the experts early, and you may find there is a much better outcome than what you're thinking about.
Perfect. Well, I'm sure there will be some highly valuable insights in today's interview for a lot of our clientele and the groups that we deal with. So, Mark, thanks very much again for making the time.
Thanks very much, and appreciate the invitation.